If you are listening to this, you are participating in an experience that is, well, it's fundamental, it's universal, and yet it's still wildly misunderstood.
Absolutely.
We are talking about the secret engine of human behavior, sexuality. And here's the punchline up front. We are going so far beyond pleasure and reproduction today.
So much further.
We are going to show you how a healthy sexual life literally protects you from getting sick by boosting a specific critical antibody called immunoglobulin A.
And maybe even more importantly, how your brain's own cognitive filter is more critical to arousal than any external touch or stimulus.
That's right. What drives us it's a complex symphony, really. Meticulously composed of deep hardwired biology, the specific cultural norms we learn, and these highly personalized thought processes.
And we are diving deep into the science that governs our deepest physiological drives and, crucially, how culture molds and directs those drives.
From the very moment a stimulus hits those specialized structures in your brain.
All the way to the physiological release that's organized right at the spinal cord level.
Welcome to the deep dive. Today, we have an incredibly comprehensive, multifaceted document exploring normal sexuality. I mean, this thing covers everything from foundational psychological theory to the incredibly minute details of the central nervous system's role in climax.
It's a lot to unpack.
It is. So our mission is direct. We are tearing down the shame and confusion, unlocking the objective knowledge, and putting you in charge of understanding your own deepest drives and responses.
And our mission for you, the listener, is really to synthesize these incredibly diverse biological and sociocultural perspectives. We want you to walk away with a clear, robust, and non-judgmental understanding of what constitutes normal human sexual expression.
An understanding informed by scientific authority, not, inherited bias.
Exactly.
Before we unpack all these fascinating details, we do want to give a special thanks to London HeartbeatsZ Academy, UK, for their educational support. They really make these deep dives possible.
We absolutely encourage you to explore their extensive offerings. They have, I believe, over 150 popular courses designed to help you stay informed and thrive across, well, all sorts of fields.
And you can stay up to date by subscribing to their social media channels, Facebook, Instagram, and YouTube for free regular updates. That way you won't miss any future amazing discussions.
And for those of you who want to go even deeper, they have a higher level of YouTube membership that gives you early access to educational videos and even the chance for personal chats and guidance sessions.
It's a great way to apply this kind of essential knowledge directly to your life. So definitely check that out. 2-second pause. Okay, so let's unpack this core concept first. The definition of human sexuality.
Right.
Our source defines it pretty simply, actually, as the fundamental process by which people experience and express themselves as sexual beings.
It sounds simple, but the fact that this has always been a primary focus of human curiosity and analysis, that tells you just how central this drive really is to our existence.
And this is where the complexity immediately begins, isn't it?
Oh, absolutely. It's not a single, isolated, instinctual drive like, say, a bear hibernating. Instead, it is continuously shaped throughout your entire life by a complex weaving together of factors.
It's like a living negotiation. We start with the biological foundation, right? The anatomy and physiology.
A basic hardware.
But then those factors are immediately layered with the specific culture a person lives in, their deep relationships with others.
And their developmental experiences across the entire lifespan. I mean, from childhood perceptions of gender roles all the way through to old age, it never stops being shaped.
So the takeaway is that the components of sexuality are just vast. It's the perception of being male or female, it's private thoughts, fantasies, and then finally, specific behaviors.
The drive exists, but the expression is customized by your environment. It's unique to you.
Our sources then try to set a clear, sort of psychological wellness-based criteria for what constitutes normal sexual behavior. This seems like a key framework for anyone trying to understand this. What does that rubric look like?
Well, and this is important. This rubric is very focused on mental health and consent rather than, say, morality.
Yep.
For a sexual behavior to be considered within the realm of normal expression, it must first bring pleasure to oneself and one's partner. That's foundational.
Mutual pleasure.
Yes. Second, it must involve stimulation of primary sex organs, which naturally includes coitus, but is definitely not limited to it.
Right.
Third, and this is so important from a psychological perspective, it must be devoid of inappropriate feelings of guilt or anxiety.
And finally,
it must be non-compulsive. The person has to feel in control of their activity, not driven by it in a way that's distressing.
that criteria about guilt and non-compulsion, that really shifts the focus entirely from cultural judgment, which so often creates the guilt in the first place, doesn't it?
It does. It moves it to individual psychological freedom. The bottom line becomes if you enjoy it and it isn't harming you or anyone else, it's healthy.
So the source then draws a key functional distinction between two modes of engagement. It talks about recreational and relational sex.
Yes, and this is a really useful way to think about it.
Recreational sex seems purely focused on the physical payoff.
Precisely. It's centered on physical gratification and release. The material includes activities like masturbation, various forms of sex organ stimulation, basically achieving gratification in ways that don't necessarily require a partner.
Okay, and relational sex.
That takes the gratification and connects it deeply to intimacy, communication, and maintaining a bond with a partner.
So it's about connection.
It is. But both are viewed as normal and necessary expressions of the drive as long as they meet those non-compulsive, no-guilt criteria we just talked about. 2-second pause.
To really bring this powerful distinction to life, this difference between a restrictive upbringing and the brain's potential for freedom, let's look at a case example that really highlights the power of interpretation.
This scenario is, it's incredibly common, and it illustrates how learned shame can literally override our biology.
So paint the picture for us.
Okay, picture a young adult, maybe 20 years old, who was raised in an environment that taught that any sexual thought or act outside of procreation was inherently sinful and shameful.
Very common story for many people.
It is. Now, this individual begins to explore their sexuality, but when a stimulus hits, even something simple like low-stakes physical intimacy, a kiss, they experience an immediate, intense spike of guilt and anxiety.
So their body is initiating the physical arousal, but their cognitive alarm system, the brain's evaluator, immediately hits the brakes and generates panic.
That's precisely it. That rapid negative cognitive evaluation creates an internal conflict that often manifests physically as, say, sexual avoidance or an inability to even achieve excitement.
So what happens? In this case, the person seeks help.
Yes, the individual in this case seeks counseling and education that provides an objective, scientific framework for sexuality. And this education doesn't just provide facts, it fundamentally challenges and shifts their entire cognitive perspective.
So the goal isn't to change the physical body, but to change the learned labels. They have to move from labeling physical stimulation as sinful or shameful to seeing it as positive, natural, or good.
And the application summary here shows the profound impact of that shift. Once the counseling and education successfully reframe how the stimulus is interpreted, the anxiety is removed.
And the normal physiological arousal mechanism can finally work properly.
Exactly. It's enhanced and facilitated. This proves that for human beings, evaluation is often the critical bottleneck in achieving a normal, pleasurable sexual response. Our sophisticated mental activity truly mediates our biological drive.
When we look at the source material, it provides this massive, almost overwhelming list of perspectives that influence sexual behavior. Philosophical, sociological, psychological, anatomical.
It goes on and on. Cognitive, learning, cultural, political, legal, moral, ethical.
Theological, spiritual, religious. It's a huge list of 15 different lenses.
It is, and I think it serves to remind us just how broad this topic really is. But for our purposes, we need to distill this down into the core scientific triad that dictates function.
The anatomical, the physiological, and the cognitive.
Those are the big three.
Okay, so starting with the anatomical perspective, we're dealing with the physical structures, right? The fundamental hardware.
That hardware includes the primary sex organs, which are the reproductive organs, and the secondary sexual characteristics, like body hair and breast development.
But the structures that are critical for the function, for generating the response.
Those are the control centers,
Right.
the nervous system and the endocrine system. The nervous system is the wiring. The endocrine system is the chemical factory that manages all the hormones.
The physiological perspective then looks at those chemical factories in action. This is the world of neurotransmitters and hormones.
These are the powerful internal drivers that, together, dictate the overall sexual drive. These are the engines that get the response cycle started.
And then comes the perspective that, fundamentally separates human sexuality from the purely instinctual drives of animals, the cognitive perspective.
And the crucial insight here is that the way a stimulus is interpreted determines the individual response. You cannot separate the physical act from the mental filter. It's impossible.
So how does the brain actually manage that interpretation? The source breaks it down into 3 perceptive components.
Right. First, there's detection, simply noting the presence of the stimulus. There is a touch, or I see an image. Very basic.
Okay, step one. Then what?
Second is labeling. This is categorizing the event. This is a potential intimate partner, or this situation is safe. You're putting it in a box.
And the third, what you're saying, is the true cognitive driver.
That is attribution. It's the process of assigning an explanation or a cause to the perception. It's the why.
For example?
For example, I feel my heart beating fast and a warmth because I am excited by this person versus I feel my heart beating fast because I am afraid of getting caught. Same sensation, totally different attribution.
And then, after attribution, we hit the defining gate, evaluation.
This is the culmination of the whole cognitive process. If the evaluation is positive, this is good, this is safe, it dramatically enhances arousal.
But if the evaluation is negative, this is shameful, this is repulsive.
It immediately diminishes or suppresses sexuality entirely, just like we saw in our first case example.
This cognitive filter is why context and your psychological state matter more than pure sensation.
Absolutely. The exact same physical sensation on the skin will produce intense arousal if the evaluation is positive, or absolute repulsion if the evaluation is negative. The meaning dictates the drive.
That breakdown of the interpretation process is complex but so critical. Let's make sure we internalize those components.
Good idea.
Okay, quick question for you listening. MCQ1. According to the cognitive perspective, which component involves assigning an explanation to a perceived sexual stimulus, effectively answering the why behind the feeling? Is it A, detection, B, labeling, C, attribution, or D, evaluation?
And the answer is C, attribution. Attribution is that key step where your cognitive system assigns the explanation or cause to what you're perceiving. That then feeds directly into the final critical step of evaluation.
Moving from the internal filter of cognition to the external forces of the environment, let's explore the learning perspective.
Learning theory, in this context, highlights how our environment conditions our sexual responses through really simple mechanisms.
So positive reinforcement.
Exactly. If a sexual activity is pleasurable, if it leads to a release of tension, a connection, a good feeling, that activity acts as reinforcement, making the behavior more likely to happen again in the future.
And conversely, if sexual activity is consistently restricted or punished or associated with profound shaming,
then the individual becomes conditioned to associate sexual stimulation with negative emotional states like intense guilt or anxiety, which in turn inhibits the natural response. It's basically classical conditioning applied to desire.
the source also notes the role of observational learning.
Yes, we learn what's normal or possible or exciting by watching others, whether that's through our peers, the media, or cultural depictions. This modeling shapes our fantasies and our expectations.
And this whole learning process brings us to the ultimate synthesis, which draws on what the source calls the Italian mentors concept of the convergence of development.
This is a really elegant perspective. It stresses that human sexuality isn't just a raw, rigid instinct, which might be true in some animals where their conduct is stereotypical.
But for humans,
For humans, the drive is fundamentally mediated and influenced by our superior mental activity and the entire spectrum of social, cultural, educational, and normative characteristics of the environment where our personality matures.
so the source insists that analyzing the sexual sphere requires convergence, a coming together of affectivity, emotions, and relations.
It's an act of complex human communication and psychological maturity, not just, plumbing.
Exactly. Our superior mental capacity doesn't eliminate the biological drive, but it imposes all these layers of interpretation, morality, and social conditioning onto that drive.
And that's what makes the human sexual response the incredibly complex system we're diving into today. 2-second pause.
Now that we understand the anatomy and the cognitive filters, let's shift our lens to history and society, looking at the frameworks that shaped how we talk about sex, even today.
Yes.
Our material cites the massive influence of foundational psychological theory from the early 20th century.
Right, and you really can't talk about this topic without acknowledging that. The central psychological theory of sexuality gave us core concepts that became the bedrock of 20th century understanding.
Like the idea of psychosexual development,
Yeah.
the oral, anal, phallic, and genital stages.
Exactly. That whole framework defined how early life experiences were thought to shape adult personality and desire. We also gain concepts like the generalization that all pleasurable impulses and activities are originally sexual in nature.
The idea that this underlying sexual energy, or libido, can be channeled into non-sexual things, creative or intellectual pursuits, a concept we call sublimation.
That's probably the most enduring legacy of that work, isn't it? The suggestion that our work ethic, our art, our hobbies might all originate from this generalized, channeled sexual energy.
So then moving forward into later 20th century thinking, we encounter the constructionist view.
Which radically challenged the idea of a universal biological sexuality.
How so?
Instead, this thinker proposed that sexuality, the activities, the labels, the sensations, are entirely determined historically, regionally, and culturally. The argument is that it's not a timeless truth, it's an invention.
And the real weight of this argument lies in its political implication.
Yes. That the construction of sexual meanings is, in fact, an instrument used by powerful social institutions, religion, marketing, the educational system, even medicine and psychiatry, to control and shape human relationships and behavior.
So it posits that sexual morality is fundamentally a tool for institutional power. That whoever defines what is normal is effectively defining what can be controlled or taxed or condemned.
That's the core of the argument.
But isn't calling all social definitions of sex control maybe a little overly cynical? I mean, where does the constructionist view leave space for healthy, voluntary social norms like mutual respect and consent, which aren't necessarily about power?
And that is the constant debate sparked by this perspective. The constructionist argument focuses primarily on the history of suppression and regulation, how institutions dictate marriage, forbid homosexuality, or condemn masturbation.
So it's a critique.
It serves as a necessary critique that forces us to question who benefits when a particular sexual expression is marginalized. It makes us aware that even our current definitions of normal are historically situated.
That structural view gives us the perfect context for our next check. So, MCQ2. Which social framework proposed that the concepts and meanings surrounding sexuality are determined historically and culturally and are often used by social institutions to exert control over human relationships? Is it A, the theory focusing on psychological stages, B, the physiological theory of tension and release, C, the constructionist view, or D, the theory emphasizing testosterone as a driver?
The answer there is C, the constructionist view. This is the perspective that emphasized that sexual definitions are historical and cultural tools, not biological truths, and are often deployed as mechanisms for institutional control. 2-second pause.
Now we get into the tremendous amount of regulation society places on this drive, sexual ethics and legality.
And it's fascinating that the source notes that vaginal intercourse, the reproductive act, is rarely made taboo on religious or legal grounds. That shows its foundational acceptance.
But the prohibition of other acts is extensive.
Incredibly so. We see examples of cultures and specific religious groups that have completely prohibited all sexual intercourse, like the Shakers, specific orders within the Roman Catholic Church, and Mahayana Buddhist monks.
But for most of human history, the ethics have focused on who, how, and when sexual acts occur.
Exactly. And the source provides a detailed list of acts often subject to ethics and legality, which act as a map of the human behaviors that society attempts to manage and often suppress.
We can probably categorize these into a few key groups, can't we?
I think so. First, you have autoerotic and non-procreative acts. Primarily masturbation, which has been subjected to intense moral campaigns throughout history, often causing significant psychological harm.
Okay. What's the second group?
Consensual, non-marital, or third-party involvement. This would include fornication or live-together arrangements, which challenge institutional marriage, and adultery or extramarital sex, which challenges fidelity norms.
Then you have non-traditional orientations and transactions.
Right. This covers homosexuality, meaning gay or lesbian relationships, which have historically been criminalized or condemned, and commercial sex or prostitution.
And fourth, and obviously most serious, the list covers the highly illegal and universally condemned acts that violate consent, safety, or core human dignity.
And these include necrophilia, incest, child sexual abuse or pedophilia, bestiality, and of course, all forms of non-consensual acts. Forceful sex, rape, sexual assault, statutory rape, and lust murder.
The list also details specific, nuanced cultural prohibitions.
Yes, like sex during a woman's menstrual period, which is prohibited in Islam and Judaism. And finally, violations of public decency, like exhibitionism and voyeurism.
The sheer length of this catalog is a powerful statement, isn't it? On the tremendous societal effort required to manage this fundamental, powerful human drive.
It truly is. 2-second pause.
Historically, the primary and really the stated function of sex was singular: reproduction.
That was the official story.
But here's where the objective, scientific deep dive offers its greatest payoff for you, the learner. Our source provides a comprehensive list of non-reproductive, demonstrable health benefits that fundamentally challenge that traditional narrow view of sexual activity.
This list is astounding because it integrates sex into holistic physical and mental wellness, moving it far beyond just pleasure.
So let's walk through the 11-cited health benefits, as these are the practical, measurable advantages.
Okay. Number one, and the easiest to understand, relieves stress. The physical exertion, the intense focus, and the hormonal release of climax naturally mitigate both psychological and physiological stress levels. It's a literal tension reliever.
Number 2 is perhaps the most surprising scientific nugget, and one we teased in the opening.
Boosts the immune system. Research cited here indicates that regular sexual activity increases levels of immunoglobulin A, or IgA.
And what is IgA?
It's a critical class of antibody found in mucosal linings like your respiratory and digestive tracts. It is your absolute first line of defense against common pathogens like colds and the flu. It's a genuine, quantifiable health boost.
So it's not just a feel-good benefit, it's a measurable defense mechanism. Okay, number 3. Improves cardiovascular system health.
The physical activity and the resulting relaxation help to lower blood pressure. Regular cardiovascular activity during sex contributes to general heart health, just like any moderate exercise.
Number 4 speaks to the relational function we talked about. Increases self-esteem.
Yes. Intimacy, connection, and feeling desired are powerful validators of self-worth and body image.
Which flows right into number 5. Improves intimacy with a partner. This is the relational function realized.
It acts as a powerful catalyst for forming, deepening, and maintaining emotional bonds, which is a foundational requirement for long-term psychological health.
Number 6 is critical for a lot of people. Reduces pain.
This is a direct pharmacological effect. It's linked to the massive hormonal surge during excitement and climax, particularly the release of oxytocin, the bonding hormone, which has well-documented analgesic or pain-reducing properties.
Then we have specific preventative health benefits for men. Number 7, decreases the risk of prostate cancer.
And the mechanism is believed to be quite straightforward. Frequent ejaculation, whether it's solo or partnered, reduces the accumulation of potentially carcinogenic or stagnant fluids within the prostate gland.
Number 8, strengthens pelvic muscles. This applies to both men and women, right?
Equally, the rhythmic muscular contractions involved in the orgasmic phase are essentially powerful, natural Kegel exercises. They strengthen the pubococcygeal muscles and support your core structure.
Number 9, promotes good sleep.
The hormonal flood post-orgasm, which includes oxytocin and prolactin, often induces a profound state of general muscular relaxation. It facilitates faster sleep onset and better sleep cycles.
And finally, a couple of truly unexpected physiological benefits. Number 10, it improves the sense of smell.
I know, it sounds strange. This temporary neurochemical effect is believed to be linked to the sharp spike in prolactin post-climax, which impacts neurogenesis in the olfactory bulb.
An unexpected sensory enhancement.
Yeah.
And number 11, which ties back to number 8.
It improves urinary bladder control, especially beneficial for women but relevant for all as those critical pelvic floor muscles are strengthened and toned.
When you look at the totality of this list, it's just clear that sexual health is a core pillar of overall human well-being.
It provides benefits far, far exceeding reproduction or simple gratification.
That immune system boost is such a powerful, actionable detail. Let's make sure we solidify that specific marker.
Okay.
MCQ3. Which physiological marker is specifically noted in the source material as being increased by sexual activity, providing a direct measurable boost to the immune system? Is it A, cortisol, B, testosterone, C, immunoglobulin A, IgA, or D, dopamine?
The correct answer is C, immunoglobulin A, IgA. The document specifically cites the increase in this critical mucosal antibody, linking regular sexual activity directly to enhanced general immune function. 2-second pause.
Moving from the macro benefits to the microbiology, let's tackle identity and the incredible complexity of the nervous system.
All right.
Our source rightly draws a crucial line between sexual identity and gender identity.
And this distinction is absolutely vital for clarity. Sexual identity is purely based on the pattern of a person's biological sexual characteristics.
To the physical stuff.
The physical, observable classification based on chromosomes, external and internal genitalia, hormonal composition, gonads, and secondary sex characteristics. It is essentially the biological assignment.
Gender identity, in sharp contrast, is a person's internal, psychological, and deeply felt sense of maleness or femaleness.
It's the internal conviction, and it may or may not align with the physical sexual identity assigned at birth.
And sexual orientation then describes the direction of attraction, the object of a person's sexual impulses.
And the source provides the classic definitions: heterosexual, attracted to the opposite sex, homosexual, same-sex, and bisexual, both sexes.
The source also mentions transsexuality, defining it as the desire to be a member of the opposite sex, which is, one component of the broader concept of gender dysphoria and identity. And finally, asexuality is addressed.
Asexuality is fascinating because the source notes the duality of perspectives surrounding those who define themselves as asexual.
What are the two sides?
On one hand, it is asserted as a positive inherent identity, a lack of sexual attraction to any object, much like a lack of attraction to a specific gender.
And on the other hand?
On the other hand, some researchers maintain that this absence of attraction may sometimes be understood clinically as a manifestation of a desire disorder, particularly when you contrast it with the strong drive observed in most humans.
So our job here is simply to impartially present both the assertion of identity and the clinical research perspective. Let's move to the ultimate control center of all this, the brain's role in sexual behavior. We start at the highest level, the cortex.
The cortex is the system that initiates and manages the drive. It controls sexual impulses and processes the complex stimuli that kick off the activity.
And specific areas do specific jobs.
They do. The orbitofrontal cortex handles the emotional weighting of the experience. The left anterior cingulate cortex is key for initiating sexual arousal and is linked to hormone control. And the right caudate nucleus is noted for tracking the progression of the sexual activity once arousal has taken hold.
It's the highest level of interpretation and monitoring.
Precisely.
Below that, we find the body's deep emotional core, the limbic system.
Exactly. This system is heavily involved in basic emotional drives. Stimulation of specific areas here, like the septum, the preoptic area, the hippocampus fimbria, are shown to elicit key physiological responses.
Such as?
For males, this stimulation strongly correlates with initiating penile erections. In females, these same general areas are tightly linked to the complex neurological and emotional experience of orgasm.
But the body needs a way to apply the brakes, right? That crucial inhibitory function is located lower down in the brainstem.
That's where the counterbalance resides. The brainstem exerts both inhibitory and excitatory control over the hardwired spinal sexual reflexes.
And there's a specific structure of interest here.
Yes, the nucleus perigigantocellularis. This nucleus projects its connections directly to the neurons in the lumbosacral spinal cord, and when it's activated, it releases serotonin.
And serotonin, in this context, is the brake fluid.
It's the perfect analogy. Serotonin is known to be a powerful inhibitor of orgasms and general sexual function. This brainstem nucleus is literally applying the chemical brakes to the climax reflex organized lower down in the body.
This brings us to the general chemical soup of neurotransmitters that orchestrate the whole response.
We have dopamine, epinephrine, norepinephrine, and serotonin all playing key roles. The source is clear. An increase in dopamine is presumed to be the accelerator pedal. It increases libido.
It's the classic neurotransmitter of seeking, motivation, and reward.
It is. And conversely, serotonin exerts a primary inhibitory effect on sexual function, acting as the counterbalance to desire and climax initiation.
It's a delicate chemical push and pull that determines our drive level.
Uh-huh.
And while the brain is the control room,
the spinal cord is the stage where the final act is performed.
So it's a reflex.
Yes. Sexual arousal and climax are ultimately organized reflexively at the spinal level. The sensory stimuli, the touch, the warmth, the pressure are conveyed from the genitalia to the spine via afferents from the pudendal, pelvic, and hypogastric nerves.
So the signal travels to the brain for cognitive processing.
But the physical reflexes for erection, lubrication, and ejaculation or orgasm are hardwired right there in the lumbosacral spinal cord segment.
Given that specific inhibitory role of the brainstem, let's test the listener on that detail. It's such a fascinating counterintuitive mechanism.
Let's do it.
MCQ4. Which brain structure is primarily responsible for exerting an inhibitory effect on sexual function through the release of serotonin, acting as the brain's central brake pedal for orgasm? Is it A, right caudate nucleus, B, orbitofrontal cortex, C, limbic system, or D, nucleus perigigantocellularis in the brainstem?
The answer is D, nucleus perigantocellularis in the brainstem. This nucleus projects to the spinal cord, causing the secretion of serotonin, which is a key inhibitor of orgasm.
Finally, let's detail the role of hormones.
Okay. Testosterone is the core driver. It increases libido in both men and women, acting as the primary fuel for desire.
And for women.
Estrogen is critical for female physiological arousal, specifically driving lubrication and potentially increasing tissue sensitivity to stimulation.
And what about the dampeners, those inhibitory hormones?
Progesterone is known to mildly depress desire in both men and women. Even more significant are excessive levels of prolactin and cortisol.
Cortisol is the stress hormone.
Right, and it's a powerful suppressor of desire. If you are highly stressed, your body is effectively shutting down the drive system.
And on the positive binding side, we have oxytocin.
Indeed, oxytocin is deeply involved in the pleasurable sensations during sex and is found at higher levels post-orgasm. This reinforces the pleasurable activity, helping to form and maintain the intimate bonds we discussed earlier. 2-second pause.
This intricate analysis of neurotransmitters provides the perfect framework to understand a very common and very frustrating real-world clinical problem associated with mental health treatment.
It does. Consider a patient suffering from chronic depression who is prescribed a selective serotonin reuptake inhibitor or an SSRI.
A very common medication.
Very. The goal of the medication is to increase the availability of serotonin in the brain, which generally improves mood and reduces anxiety. However, the patient returns reporting a significant, often devastating decrease in libido and difficulty reaching orgasm, a condition known as anorgasmia.
Before this deep dive, that might seem like a totally unrelated side effect, but now it makes perfect neurochemical sense.
Absolutely. This scenario perfectly illustrates the antagonistic relationship between dopamine and serotonin. The increase in serotonin levels, while beneficial for mood, simultaneously activates that powerful inhibitory effect on sexual function that originates in the nucleus pterygigentis cellularis.
So the boosted serotonin literally overrides the presumed positive effects of dopamine, which is what typically drives libido.
The medication designed to stabilize the patient's mood is inadvertently applying a powerful chemical brake to the climax mechanism organized in the spinal cord. It proves how tightly interconnected our mood and physical function are at the neurological level.
It's a classic example of a pharmacological intervention targeting one complex system, in this case mood, and inadvertently impacting another, the reflex system for climax.
It's a concrete application of those precise chemical rules.
Let's confirm the core hormone responsible for driving that initial desire.
Okay.
MCQ5. In both men and women, which hormone is the primary driver associated with increasing libido? Is it A, estrogen, B, prolactin, C, cortisol, or D, testosterone?
The answer there is D, testosterone. The source material confirms that testosterone is the essential hormonal driver that boosts libido in both sexes. 2-second pause.
We've established the hardware, the chemical drivers, and the cognitive software. Now let's map the psychophysiological experience itself.
Right, charting the 4 phases of the human sexual response cycle as documented by that foundational observational research.
It's vital to remember that arousal is a true psychophysiological reality, isn't it?
It's a feedback loop. It's triggered by both psychological stimuli fantasy, emotion, anticipation, and physical stimuli like touch, sight, and smell. The resulting tension is experienced both physically and emotionally.
And the quality of this entire response cycle is fundamentally mediated by those cognitive factors we discussed earlier.
Your psychosexual development, your current psychological attitudes towards sexuality, and crucially, your feelings and attitudes toward your sexual partner. All of it matters.
So the physiological engine driving this cycle involves increasing levels of 2 core phenomena.
First, vasocongestion, which is the increased blood flow leading to the swelling and engorgement of tissues, often called tumescence.
And second,
Myotonia, which is the increased muscle tone experienced across the entire body. The subsequent release of that intense vascular activity and muscle tension is called detumescence, which happens as a result of climax.
before we define the phases, we need the catalyst: sexual stimulation or foreplay. Our source divides this into psychological and physical.
Psychological stimulation can be internal or external, the use of smell, taste, hearing, sight, or the incredibly powerful use of fantasy.
And physical.
Physical stimulation involves the use of touch pressure or bodily contact. The source is comprehensive in its level of examples: erogenous zones, kissing, breast stimulation, oral genital stimulation, anal stimulation, and manual stimulation of the genitals. These are the inputs that fire up the entire system.
Now that we understand the inputs of the basic mechanics, let's make sure we clearly understand that physical engine.
Good idea.
MCQ6. The physiological process identified by Masters and Johnson, involving dramatically increased blood flow to the genitalia leading to swelling or engorgement, is known as what? A, myotonia, B, detumescence, C, vasocongestion, or D, refractory period.
The answer is C, vasocongestion, which is the engorgement of tissues with blood that causes tumescence. Myotonia is the corresponding increase in muscle tension.
Okay, so the first phase is desire, or the appetitive phase.
This phase is almost entirely mental and emotional. It reflects the psychiatric concern with underlying motivations, drives, and personality.
So it's characterized by fantasies.
Sexual fantasies, the attraction to a specific love object, and the strong subjective desire to engage in sexual activity. It's the moment your mind says, I want.
Phase 2 is excitement.
This is the physical and subjective takeoff. It's triggered by the psychological or physiological stimulation we just mentioned, or both, and consists of a conscious, subjective sense of pleasure and excitement.
And during prolonged excitement,
the body begins those intense physical changes. Vasocongestion leads to tumescence and lubrication, myotonia begins, and nipple erection may occur. This phase is highly variable. It can last anywhere from several minutes to several hours.
Phase 3 is orgasm.
This is the peak, the rapid release of all that accumulated sexual tension. It involves the rhythmic, involuntary contraction of the perineal muscles and the pelvic reproductive organs. And the mechanics differ precisely between the sexes.
How so?
For the male orgasm, it involves a subjective sense of ejaculatory inevitability, followed immediately by the forceful emission of semen. That involves 4 to 5 powerful rhythmic spasms of the reproductive structures like the prostate and seminal vesicles.
Yeah, for the female orgasm.
It's characterized by 3 to 15 involuntary contractions of the lower third of the vagina, occurring at specific 0.8-second intervals, along with strong, sustained contractions of the uterus, which flow from the top of the uterus down toward the cervix.
Phase 4, and perhaps the most important for comfort and satisfaction, is resolution.
This is when the body returns to its resting state, primarily through the disgorgement of blood from the genitalia detumescens or the loss of swelling.
And the emotional and physical experience of this phase is entirely dependent on whether orgasm occurred.
Entirely. If orgasm occurs, resolution is rapid, typically taking 10 to 15 minutes. It's associated with a profound subjective sense of well-being, immediate relaxation, and a release of generalized muscular tension.
But if orgasm does not occur,
resolution is dramatically slower. The source notes it may take from 2 to 6 hours, and some documents extend that time frame to potentially half a day or even a full day.
and this leads to discomfort.
Yes, this protracted detumescence leads to discomfort, general irritability, and dissatisfaction due to the prolonged, unrelieved vasocongestion and myotonia.
And here is a key biological difference between men and women.
Right. After orgasm, men experience a refractory period, which can last anywhere from minutes to many hours, during which they cannot be stimulated to further orgasm.
For women,
Women, biologically, do not have a mandatory refractory period and are fully capable of experiencing multiple successive orgasms, sometimes within minutes of each other.
that difference in resolution time is a critical factor in relationship communication and satisfaction. Let's clarify that time frame.
Okay.
MCQ 7. If orgasm does not occur, what is the source-cited range for the resolution phase, during which prolonged vasocongestion may lead to irritability and discomfort? A, 10-15 minutes, B, up to 30 seconds, C, 2 to 6 hours, potentially up to half a day, or D, 12 to 1 day, or even longer.
While the time frame can be highly variable, the most precise answer reflecting that discomfort range is C, 2 to 6 hours, potentially up to half a day. The key distinction is that this process is slow and uncomfortable, contrasting sharply with the rapid relaxation that follows climax.
The source also provides these generalized response patterns, A, B, or C, that an individual may experience during any given sexual encounter.
Right, reflecting the variability of human experience, whether it's a rapid climb to climax or an extended plateau with multiple peaks.
And summarizing the time frames just helps set context. Excitement lasts minutes to hours. The orgasmic phase is exceptionally brief, only 3 to 15 seconds.
And resolution is swift post-climax, 10-15 minutes, but drags painfully if climax is not achieved, 2 to 6 hours or more. 2-second pause.
We move now into the high-detail physiological changes documented by the original observational research. This is where we see the body's precise orchestration in action, starting with the detailed male sexual response cycle.
Let's focus on the central piece, the penis. Erection is rapid, often achieved within 10 to 30 seconds, thanks to the intense vasocongestion of the corpus cavernosa. With heightened excitement, the length and diameter increase further, maximizing size.
And during the orgasm phase, the physical release involves 2 stages of ejaculation.
First, the emission phase. This involves the contractions of the vas, seminal vesicles, and prostate, pushing fluid toward the urethra. Then ejaculation proper, marked by strong rhythmic contractions of the urethra resulting in the ejaculatory spurt.
And here is a fascinating yet sobering detail from the data regarding aging.
Yes, the force and distance of that ejaculatory spurt declines significantly with age. The source notes it can be 12 to 20 inches at age 18, but decreases progressively, reaching what the source describes as seepage by age 70.
That highlights a measurable age-related decline in muscular contractility.
It does. And during resolution, there is partial involution of the penis in 5 to 10 seconds, and full detumescence takes 5 to 30 minutes, followed by that variable or refractory period.
What other visible changes occur? The skin often shows an inconsistent sexual flush just before orgasm, often starting on the chest and abdomen.
And perspiration is also noted, particularly on the soles of the feet and palms of the hands.
We absolutely must highlight the role of the Cowper's glands. This is a critical piece of practical knowledge for the learner.
It is. During heightened excitement before the main orgasm, these glands secrete 2 to 3 drops of mucoid fluid. And crucially, the source confirms this fluid contains viable sperm.
That specific detail proves why pre-ejaculate is a real risk factor in unprotected sex. What about the scrotum and testes?
During excitement, the scrotal sac tightens and the testes lift, elevating toward the body. With heightened excitement, they can increase in size by 50% over the unstimulated state and flatten against the perineum.
And this size increase is a signal.
It's a reliable internal signal of impending ejaculation. They descend back to normal during resolution.
And finally, the immense systemic response involving myotonia, cardiovascular, and respiratory systems. This sounds like a full-body athletic event.
It truly is. Myotonia involves semi-spastic contractions of facial, abdominal, and intercostal muscles, often leading to a temporary loss of voluntary muscular control during climax.
And the cardiovascular response.
It's intense. Heart rate can spike up to 175-180 beats per minute. Blood pressure dramatically increases up to 40-100 millimeters systolic. And the respiration rate can reach up to 40 breaths per minute.
This level of physical exertion and vascular pressure just demonstrates the immense, controlled strain the body is under during the orgasmic phase.
Absolutely.
The pre-ejaculate detail is so crucial for practical knowledge.
It really is.
So let's do an MCQ8. According to the detailed physiological cycle, during which specific phase do the Cowper's glands secrete fluid confirmed to contain viable sperm, often before the main ejaculation begins? A. Desire. B. Excitement. C. Orgasm. Or D. Resolution.
The answer is B. Excitement. This mucoid fluid is secreted during the heightened excitement phase, often called the plateau phase, well before the contractions of the orgasm phase itself.
Now let's turn to the equally precise, detailed female sexual response cycle, starting with the clitoris.
The clitoris, a purely sensory organ, enlarges due to vasocongestion during excitement. A fascinating detail is that just before orgasm, the clitoral shaft retracts dramatically into the prepuce.
Why does it do that?
It's a mechanism possibly designed to protect the highly sensitive tissue during high-intensity pelvic movement. It makes it less accessible for direct touch. It then returns to its normal position during resolution.
The breasts also show significant, though variable, changes.
Nipple erection occurs in about 2/3 of women. And importantly, the breast tissue itself experiences venous congestion and areolar enlargement, increasing overall breast size by about 1/4 over the normal state. Tremulousness or fluttering is sometimes noted during the resolution phase.
The vagina shows the most dramatic and rapid preparatory changes during excitement.
It does. The initial sign of arousal is the rapid appearance of vaginal transudate, or lubrication, which can appear as quickly as 10 to 30 seconds after stimulation begins.
And this lubrication is accompanied by other changes.
Yes, a color change from pink to red to deep red due to vasocongestion. The vaginal barrel also undergoes elongation and ballooning.
And a crucial detail just before climax.
The lower third of the vagina, known as the orgasmic platform, constricts significantly just before orgasm begins. This constriction is followed immediately during the orgasm phase by those 3 to 15 powerful involuntary contractions of that lower third at 0.8-second intervals.
Along with uterine contractions.
Yes, strong, sustained uterine contractions.
How do the labia minora and majora respond?
The minora increase dramatically in size, 2 to 3 times their normal state, and deepen in color, acting as a reliable physiological signal that orgasm is imminent. The majora show congestion and edema, or swelling, in women who have given birth, or they elevate and flatten against the perineum in women who have not.
In the uterus.
During excitement, the uterus ascends into the false pelvis. Labor-like contractions begin just before orgasm and persist throughout the climax. It then descends back to its normal unaroused position within seconds to minutes after resolution.
And finally, the other systems mirror the male response.
Similar systemic myotonia, hyperventilation, and tachycardia, plus the noted mucoid secretion from the Bartholin's glands assisting lubrication.
Let's check that specific anatomical change in the vagina just before climax.
Okay.
MCQ9. During the excitement phase of the female sexual response cycle, what specific change occurs in the lower third of the vagina just before orgasm begins? Is it A, ejaculate forms seminal pool; B, color changes to light pink; C, constriction, forming the orgasmic platform; or D, elongation and ballooning?
The answer is C, constriction, forming the orgasmic platform. While elongation and ballooning happen earlier in the excitement phase, the specific constriction of the lower third occurs just before the transition to orgasm. 2-second pause.
We've covered the biology, the chemistry, and the detailed cycles. Now let's get practical and talk about how to optimize the experience. The source provides a simple, memorable framework for enhancing the sexual experience.
Nice.
The SX points for SECX.
This framework is an excellent tool for self-reflection and communication in a relationship. It covers preparation, mental and physical readiness; position, finding comfort and effective leverage;
Duration, ensuring adequate time for the full cycle; concentration, staying present and focused;
and relaxation, releasing mental and physical tension; and finally, frequency, maintaining a healthy rhythm that supports intimacy.
Let's delve into one of the most profound and sometimes misunderstood areas: gender differences in desire and arousal.
Yes.
The source notes that while sexual impulses and desire exist in both men and women, males generally possess a higher baseline level of desire than women.
And the differences extend significantly to what acts as the primary erotic stimulus. Men are noted to respond sexually much more quickly and intensely to visual stimuli, like nude or barely dressed women. It reflects a drive that is often more immediately physical.
Women, conversely, report responding sexually to context, to romantic stories featuring a tender, demonstrative hero whose passion impels him toward a lifetime commitment to the heroine.
This suggests that for women, context, emotional safety, security, and relationship investment are often the primary keys to activating full arousal. It often overrides purely visual cues.
But here's the critical scientific difference, which often leads to communication breakdowns: arousal congruence.
The source points out a fundamental disparity. A woman's subjective sense of arousal, what she consciously feels, is often not congruent with her physiological state, what her body is physically doing.
So her body might show clear physical signs: lubrication, vasocongestion, nipple erection, but she might not consciously feel intensely excited.
Exactly. Her physical lubrication may simply reflect a physiological readiness to become aroused rather than a conscious felt excitement. She may also experience those physical signs of vasocongestion without being subjectively aware of them.
And the source emphasizes
That this disjuncture between mind and body rarely occurs in men. For a man, if the body is physically aroused, the mind is almost always aware of that excitement. This is a profound insight into understanding partner needs.
that difference in mind-body connection is just fundamental for understanding intimacy and avoiding miscommunication.
It really is.
So MCQ 10. Which of the following is considered the primary difference in arousal congruence between the sexes, according to the sources?
Yeah.
A. Men can achieve climax without conscious awareness of physical signs. Women's physical arousal often reflects readiness for sex rather than conscious subjective excitement. C. Men typically require context and emotional commitment for full physiological arousal. Or D. Women possess a mandatory refractory period following orgasm.
The answer is B. Women's physical arousal often reflects readiness for sex, rather than conscious subjective excitement. The document highlights the frequent incongruence between a woman's felt arousal and her physiological readiness, a phenomenon that is uncommon in men.
Tying this biological analysis back to our psychological needs, we revisit the concept of love and intimacy. The foundational idea that psychological health requires the ability to function well in work and love remains paramount.
The capacity to give and receive love with minimum fear or conflict is what allows people to develop genuinely intimate relationships.
And the source is very clear on the function of sex in this context.
It is. Sexual activity frequently acts as a vital catalyst in forming and maintaining these intimate relationships. It's the ritualized bond reinforcement.
Finally, let's address frequency of sexual activity. The natural range is huge, isn't it? Spanning from zero, abstinence, up to 15 to 20 times per week.
It demonstrates the wide variability of human need. The average for married U.S. couples is cited around 2 to 3 times per week.
And the source notes a general and predictable trend.
Frequency declines with age in both men and women, specifically noting that postmenopausal women experience declines due to hormonal shifts and other factors.
The Kinsey Institute data gives us precise benchmarks, illustrating this inevitable decline. Age 18-29 averages 112 times per year.
Declining to 86 times per year by age 30-39 and reaching 69 times per year by age 40-49.
And the decline continues steadily.
52 times per year for age 50-59, dropping to 35 times per year for age 60-69, and settling around 22 times per year for age 70-79. This data sets realistic expectations. It illustrates that while the drive persists, the frequency is subject to physiology, time constraints, and relationship history. 2-second pause.
Let's use that reality check on frequency and the concept of sex as an intimacy catalyst to look at our final case study. This one focuses on how conscious effort can counteract the inevitable decline of routine.
Okay. Consider a long-term couple in their late 40s, right in the middle of that 69 times a year Kinsey average. They report that their sex life, though once passionate, has become highly routine, predictable, and infrequent.
And that's leading to noticeable relationship strain, precisely because the catalyst function of sex has deteriorated.
Exactly. They love each other, but life and stress have choked the spontaneous desire.
So their solution isn't to look for some magical new technique, but to apply the objective science of the 6p6 points for SX.
That's right. They recognize they can't just rely on spontaneous desire anymore. So they address concentration by establishing strict rules about putting away technology and work stress well before intimacy.
And they focus heavily on preparation.
Very heavily. They're literally setting dedicated, anticipated time for their physical relationship rather than just waiting for the perfect, spontaneous moment to strike.
And the result is that this conscious structure revitalizes the experience. By applying concentration and preparation, they successfully increase their frequency,
which in turn reinforces their intimate relationship. This demonstrates that for long-term partners, conscious application of objective factors is often the key to revitalizing and maintaining that crucial relationship bond.
So, in conclusion, what this deep dive into your source material has powerfully revealed is that human sexuality is far from simple instinct.
Far from it. It's profoundly complex and multidimensional behavior, affected simultaneously by anatomy, physiology, cognition, learning, and massive external forces like culture, ethnicity, economy, and politics.
And because of that immense complexity, the source material makes a final, urgent appeal for education.
It stresses that sex education is desperately needed in every society, specifically in the school curriculum, because faulty learning and shame-based learning about sex can fundamentally misguide a person's life and produce a lifetime of sexual and psychosocial problems.
And that knowledge must be objective, unbiased, and authoritative.
It must come from a scientific authority, not solely from cultural or theological constraints, to ensure the next generation understands their own bodies and minds without fear.
To synthesize the core, most critical points for you, the learner, here are 5 non-negotiable takeaways from this deep dive.
Okay, number 1. The cognitive filter is king. The normal sexual response is a continuous dance between biological hardwiring and cognitive filtering. Your interpretation, specifically that final step of evaluation, is the psychological determinant of whether your brain enhances or diminishes arousal. Learned shame can kill natural desire.
Number 2. The neurochemical antagonism. There is a clear chemical struggle between desire and inhibition. Dopamine enhances libido, while serotonin exerts a primary inhibitory effect. This fundamental insight explains why many common medications for mood stability inadvertently suppress sexual function by boosting that chemical brake.
3. The measurable health dividend. Sexual activity offers extensive, quantifiable health benefits, from profound pain reduction due to oxytocin release to the critical immune system boost achieved through the increase of the antibody immunoglobulin A, IgA.
4. The arousal congruence gap. Gender differences exist not just in baseline desire, but critically in arousal congruence. A woman's physiological arousal, like lubrication, often reflects readiness rather than conscious subjective excitement. This is a disparity that rarely occurs in men and is vital for communication.
And finally, number 5. Intimacy endures, frequency declines. Sexual frequency declines significantly and predictably with age, following clear Kinsey benchmarks, but the capacity for intimacy and connection remains essential, and sexual activity continues to function as a vital catalyst for maintaining long-term relationship bonds.
We've charted the science and the sociology, but here's something for you to mull over as you carry this knowledge forward. Given the constructionist idea that social institutions use sexual meaning to control human relationships, by defining what is normal and taboo, how might a truly scientifically informed, culture-neutral sex education curriculum fundamentally shift political and social power dynamics in the next generation?
How would it shift things by taking control of the definition of health and normalcy away from institutional dogma?
A complex thought that requires critical exploration as you integrate this new objective knowledge.
It certainly is. Thank you for joining us for this deep dive into your source material.
Until next time, keep digging into the details.